There you go.
How are you? This is
Yeah,
9 o'clock.
good.
Perth morning, is it?
It's like 10 a.m. here.
That's
Yeah,
all right.
yeah. So it's not too bad. Already done like 3 hours of sessions.
Oh, geez.
Yeah.
There you go. All right. This is Jeremy, by the way. This is Kieran. Hey, yeah.
Hey, Jeremy, how you going, mate?
This is Rani. She's coming in. This is Kieran.
G'day, Ranny.
Hey, how you doing? One more to join us.
Yeah, good.
Kelvin's coming.
Yeah, good. All right, cool.
That's all right.
All right, cool. So, is this are we doing cervicogenic dizziness?
Yeah, that'd be great. I'm just even, I guess, sort of being able to differentiate from other forms of business that we might encounter in the clinic.
Yeah, yeah, and like, when I did the specialist training, basically I'm Musk, right? I'm MSK.
Yeah.
But what I'm going to give you will be as much as you would need to know in MSK to differentially diagnose.
That's right.
Yeah, because it gets a bit like if we're talking vestibular, it's a bit more specific, right? Like
yeah, that's more like what we're looking for here.
like more just like a general. Like
yeah. Like none of us do something vestibular physio.
No, I'll give them a crack even now, but I probably see 2 to 3 a year, probably.
Yeah. Well, we've got a pretty good way we've got people to refer on to.
Okay.
But we'll still encounter it. We may encounter it within a session or a lot with like a neck patient, especially like a whiplash kind of thing. And I'm trying to work out, is it something we can treat or is it something we need to refer on?
Yes. Yeah.
And it's like, like who do we refer on to?
Yes. Yeah. We'll go through that. Yeah. Because you sort of like, you don't want to send them off unnecessarily. And a lot of them we can fix, to be honest. Like it's most of it is within our scope of practice. But then there's some where you sort of just like, well, if I've tried this stuff and they're still not right, I probably should shoot them off.
Yeah. Cool.
Yep.
I haven't just got Rochelle. Rochelle she's going to appear. So I don't know if you want to. Could you give the guys just a couple of minutes to start to tell them what global physio does from an education point of view? If we're going to, because it's 15 times. I've explained it, but it's better coming from yourself.
Of course. Yeah, I'll pull up my PowerPoint. Where are we? So that's the topic for today. And if you don't know who I am, my name's Kieran. I'm a specialist physio in Musk. And I run a consultancy company where we mentor and train physios all around Australia, but also internationally. And in Perth, I also give a lot of second opinion, like most days of the week. And so clinics will kind of use me and my team as independent voices. So just to help consider a counter perspective. So this is an example of a patient that asked for a second opinion, and then the physios, they kind of meet up in their lunchtime, and then we also go and do workshops and training. This is a group in Brisbane, but we do all areas across the body. So it's not just limited to, it's MSK sports and pain is the main stuff we do. And if you don't already, you can follow me personally on LinkedIn, Dr. Kieran Richardson, and then on Instagram is the main one, global_specialist_physio. On LinkedIn, I'm more professional. On Instagram, I joke around a lot more and use memes and stuff like that. I probably borderline unprofessional, but who cares?
Learn best like that.
Yeah. Well, there's actually one study I use sometimes. Like I presented at a workshop on the weekend, and it's actually called meme science. So you can actually healthcare professionals are more likely to read your post or article if you have a meme first. So it's called meme science. And so like I actually use it. I used it in my presentation on the weekend.
Excellent.
Yeah. But that's our website. If you haven't been on it, you can go on there and see. So yeah, I do it full time, and my team are a mix of academics and expert clinicians, so all postgrad trained or heading towards specialist titling or PhD. And so like we do a lot of, so sometimes as well, like even with clinics over East, they'll book in a patient in this time like you've got now. They'll book in, as long as the patient's cool with it, and we'll run an assessment virtually. That's the other thing we do. So we do second opinions here face-to-face in Perth, but we also do like insurance second opinions interstate, and it works really well. That's some of the team, and most of them are based in Perth, but we've got some in Melbourne, some in Canada, and some in Sydney. So this topic, I am definitely not a guru when it comes to vestibular. I'm not a guru. In fact, if you can catch what I'm telling you, it's all you'll need to know as a generalist physio. You don't need to know more than what I'm showing you, which should give you confidence. But I normally like to start with a case study because it'll kind of pull it all together. But I'll need you guys, the way I tend to teach and the way we tend to teach is we like it to be super interactive. So you might want to take notes. And I'll be asking you a lot of questions.
Nice scrolling.
Okay.
Yep. All right. I'm note taker for the day.
So this is a real patient. This is a real patient that I saw a few years ago, and it made me look into this topic really in detail. So she was a 56-year-old female. She was full-time home duties. She lived with her son, and she lived with her husband. She also lived with her father-in-law, who was like pretty aggressive. Like I got the impression their home environment was a bit toxic. And she was a bit of an anxious patient, to be honest. She had experienced this 23 to 24-year history of constant lightheadedness. Like she described it as being woozy, like her head was kind of woozy and floaty. And she'd have these spikes of floatiness that were worse, but generally this constant mild dizziness was there. There was no incident. Although, yeah, there's no specific incident per se. But she reckons it started, it's a bit full on, but she reckons it started when she had 2 near full-term stillbirths. And so she said it was like, it kind of, she felt like it had started around that time, which is pretty full on. It had been getting worse prior to seeing me, probably related to the hostility between her and her father-in-law. And he'd just been hospitalized. I think he was like sort of dementing, you know. She saw a doctor who sent her for a CT scan of her head, which was fine. Okay. She then saw a GP who said, see a physio to do hands-on on your neck because he thought it was tension. Right? Like tension headache kind of thing. Okay, so whenever you're seeing these patients, it's exactly like MSK pain. Like you get them to describe, like you would do a 24-hour pain chart for pain, you do the same kind of thing for dizziness, right? So she said it was swaying, lightheadedness. It was like a 1 or 2 out of 10 in terms of problematic for her. When it got bad, it would sometimes last a fortnight, almost feeling like she was going to fall over. Okay. Here's what would aggravate it. Sweeping, walking for more than 5 minutes, getting stressed, working on a computer for more than 2 hours, reading a book, laughing, and sometimes when she drove. But she couldn't really like bed down the pattern when she was driving, but these other ones were pretty specific. It was better when she'd lie down and when she'd relax, when she felt relaxed. She took Mobic for her knees. Okay. Here's a medical history. She did have an MVA as a 16-year-old, but that was like however many years ago, 35, 38 years ago. And she didn't have any persistent whiplash or dizziness after that. Anything else there that you need clarification on?
Not really.
No. She slept poor. So I always ask patients about sleep, and she slept poorly. And she wasn't doing any exercise at all. This is where it gets a bit interesting.
It's a bit harsh.
The previous physio said that she was too fat and she had no neck, which I think is completely savage. And you can't really unsay those words, right? So that was that one's always stuck with me. And he didn't even give her any exercises to help her get rid of that anyway. She felt like it was neck tension. Okay. And she kind of just wanted to get rid of it. Like, as much, I always ask the patient, well, I guess, what do you want out of this session? Like, what are you hoping to experience out of physio? What's your expectation? She was like, I just want to feel better. Like, I want to feel more comfortable, take control of it. She said she felt like there was some kind of link between her neck and her dizziness. Okay.
Yeah.
Now, what I want you to do, maybe Rennie and Dave and the other two.
Jeremy and Rochelle.
Jez, and what's the other one?
This is Rochelle.
Rochelle. Okay, sorry. Yeah, I can see that. Can you pair up and tell me what you think? Here's what this is how I normally like to do it. I want you to write down what you think your differential diagnosis might be right now. Okay. I want you to write down if you think there's anything else subjectively that you'd want to know that I've missed. And it's by no means comprehensive, but and then I also want you to write down what you would be planning to do in the physical exam. So I'll give you like 3 or 4 minutes to do that. And you can ask me any questions you want.
She did she expand anything on the child? What happened during the childbirth, or till you like?
She just said, like, I'll be honest, like, it was pretty harrowing when she was telling me.
Yeah.
She was like, she started crying like when she was telling me, and it was just traumatic. You can tell it was full on. It was like, I mean, what are you meant to say as a therapist? But like, how are you meant to come back from that? She was just kind of like, it just devastated her. And I think she had her son. She had her son after those. Those were after her son as well. So yeah.
But she got anything that eased it, that makes it feel better.
She said just like she sort of said lying down supine, and just when she was more chilled, when she didn't have stuff going on, and socially particularly, yeah.
There's like 2 components.
If I get this right.
Yeah. So I think there is some position stuff.
Yeah, oh yeah, definitely.
Because sweeping, reading, and even
anything, yeah.
If she's doing.
I love that.
Topics like sections, operation vital stuff, and the stress of talking about.
Yeah.
We know also that satisfaction.
Yeah.
Severely. I'd be doing probably a questionnaire, something stress, there's a stress. I'd be doing it, I reckon it's a stress inducement stimulant on migraine. Going for it. Probably wouldn't be. I'm not gonna do it, but. Could it also be?
So we've got two components here, right?
There's quite a few components going on. There's
You got
like,
the big psychosocial issue with like stress related
yep,
component.
Yep.
And then for me, I'm sort of sitting there going, it looks like there's a mechanical sort of like upper cervical extension part of it that's really sort of overloading that your upper cervical spine really.
yep.
So those are the two elements that I sort of strike me at the moment.
That's good. Anything else?
Could maybe be making her, does it have side effects to that?
I don't know, I'm always a bit sus about thyroids, because they just seem
Look, there's hundreds
yeah.
of. I expect you guys to have written down hundreds of possible differential diagnoses because there's hundreds of forms of dizziness. So, yeah. So you never exclude anything. You always like. I've learnt that I'm always trying to rule in and rule out, and I always keep even my primary diagnosis kind of loosely held because sometimes you get it wrong. It's always like a balance of probabilities, right? Like you're always just trying to like. You look at the case and you think, where's most of the evidence pointing towards? But sometimes it's not just one. Like I think of it like like each patient's like a kaleidoscope, right? Like they're a unique presentation. No one's the same. But there'll be like clusters of features that are more like a traditional diagnosis. So but you can have. It's almost like dualism or trialism, like where you can have two or three things existing at the same time that aren't contradictory. So you could have, like Dave said, you could have psychosocial and neck, or you could, so you've always, but the good therapists, right? What they can do is they can go, okay, based on my subjective, based on my physical, I think it's like 40% neck. I think it's like 30% social, and I think it's like whatever the other percentages, 30% bloody don't know, or it could be this, or it could be. So that's kind of how I every time I'm looking at a case, especially if they're complex, I try to like weigh up the percentages. If that does that make any sense?
Yeah.
Yeah, and like that, but then if you go one step further, the really good physios can, based on those percentages, prescribe specific information. Like they can weight their exercises and their treatments. So like if you've got 20 minutes to treat, you'll spend 40% of that on the 40%. You'll spend 30% on the other 30%. You know what I mean? Like you kind of like don't, yeah. So you like spread it out based on their presentation. Yeah. So that's how I tend to think of these more challenging ones. Any other questions or comment? I don't know about the Mobic. There probably is. There's always like, whenever someone's got comorbidities, you've always got to think. Like I've got a girl at the moment, right, who's a very complex case. She's seen quite a few people in Perth. She's got neck and arm. She's got persistent neck and arm pain and pins and needles. She's had MRI neck, shoulder, elbow, chest. All of it negative. She gets relief with physio and she's slowly getting better, but I think she's got thoracic outlet. So I sent her to a GP who's pretty hopeless, to be honest. And I had to basically tell the GP what to do. So I said, look, send her to this rheumatologist. And the rheumatologist was really good. He like took control of it and like started ordering all these tests. But the other thing is this all started when she started ADD medication. And so the rheumatologist is then sending her to a different psychiatrist to like tinker with the meds. And so what you start realizing is everyone at some point starts to realize with these complex cases, okay, I could be wrong and it could actually be the medication, or so you always like have it in the back of your mind. So I think it's good that you call out the Mobic. Yeah. Anything else you want to think or got any ideas?
The blood pressure, cardiovascular stuff.
Yep, that's very good. So what other physical things would you plan to do with her?
On top of that. Objectively.
Yep, objectively, what are you going to do with this patient? to rule in and rule out, and then I'll tell you what I did, and then we can.
Suppose you could just, if you've got a blood pressure monitor, just check what blood pressure does from sit to stand or from lying to sitting. Because she does have she's better when she lies down. She's worse when most of the things she does is in an upright position. So is there some sort of discrepancy going on there?
Yep. Very good. Jez, what are you thinking? Are you thinking, you're probably thinking high cervical manips?
No, objectively, like your BBI checks.
Yeah, good, very good. Yep, and if that's positive,
But
yep.
But it could also be like the thing too, but anyway. But yeah.
Yep. What else? Rochelle, was it?
There's lots of neck, range of motion and tests, and I'll check all the cervical ligaments and stuff like that.
That's good. Good. Yep, excellent. So, here's what I did. Physical exam. It's by no means perfect. As I said, I'm not the world's best cervicogenic dizziness, but I don't think anyone really is, but I can teach you enough to get by. So she had there was no issues in terms of like stroke features. Okay. She sat, the thing that struck me is she was very stressed, like quite anxious. You know, you see those patients and you just look, why is this person so stressed out? Her jaw was stuck out and she was like upper chest breathing. Okay. Her VBI was negative. Her carotid pulses were fine. Her cervical range of motion was fine. Her unilateral upper cervical spine palpation, so articular pillar and facet joints, normal. Her upper traps length was reduced for what I would expect compared to her age demographic. She was tense. When I touch her upper traps, they were painful. They were tense. Her cranial nerves were fine. Her cerebellar test was fine. And I threw in a Dix Hallpike, and that was also fine. Okay. Well, I did sensory motor testing. Her joint position error. Do you guys know these? Someone asked, hey, what was that?
It's been a while.
The joint. Oh, look.
Yeah. Is that a laser?
It's a laser. It's a laser. I don't even use the laser. I'll show you how I do it. It's like real basic. Her eye follow was fine, and her gaze stability brought on some positive lightheadedness. When I got it, I did like a full balance assessment with her as well. Probably this all took me about 45 minutes. Her eyes closed, she was fine, but when I got her putting her left foot forward, like a Romberg sharpened with a left forward, and her eyes were closed, she'd get the dizziness. If you don't use it already, you can use a dizziness handicap inventory.
All right.
That's like a patient-reported outcome measure. And hers was mild to moderate. Okay. All right. What I want you to do is come up with your diagnosis. So maybe discuss it with a partner, or a differential diagnosis in rank and order. Based on what I've told you, subjectively and physical, what is the main diagnosis you'd pin your hat on? And then what treatment might you do or offer for this case? And then what are you going to do? And then the other thing, which I think Dave and I have spoken about, this whole idea of a treatment plan, right? Like at some point, maybe we could do some training on treatment planning, which is probably one of my favorite things to talk on, because it's like, it's the best thing you can do, honestly. Like patients love a plan. The guidelines tell us patients should be given a plan. The APA wants us to give plans. In specialist training, every single patient gets a plan. It does work. It does work. But it'd be nice to know what you would be thinking based on your initial consult. You can sort of break it down like if you want to be super comprehensive, you've got phases, right? Like symptom relief. Phase 1. Phase 2, building capacity. Phase 3, lifestyle. That's how I tend to teach it and see it. But then if you're breaking it down more simply, you want to know how many times am I going to see this patient over how many weeks in each phase? And what am I going to do? And what do I expect her to do? And then you've got, in summary, your diagnosis, your dosage, which is how many appointments recommended, and then your prognosis, outcome, timeframe, and best result. Do you want me to repeat those, or does that make sense?
That makes sense.
Yeah. And like, so every single case I see, not just cervicogenic dizziness or vertigo, I'll look at them and I'll think, I've got to summarize all my clinical reasoning to them in a way they understand that gives them a practical plan that they can take away and tell their friends and family. And the patients love it. And I think Dave was saying you guys are pretty good with that.
Okay.
Not bad.
No, this is your.
We do have sort of treatment maps and treatment plans for quite a lot of things. But like sort of more broad areas like sort of extension-based back pain and that kind of thing. So
yeah,
we do have those things.
It's pretty, in my opinion, it should be a non-negotiable in both public and private. In here in West Australia for workers' comp, it's a mandatory. You have to give it mandatorily for any new patient. They have to be given a plan. And whenever I do because I do a day of second opinion a week, right, face to face, it's the same story. All the patients I see have not been given a comprehensive plan. So I'll say to them, "What's the plan?" And they go, "I don't know." And so then my job is to basically try to write out a plan for them. So for this patient, I want you guys to write out a plan if you can. You can collaborate with a partner. And there's no right or wrong, but I'll tell you what I did.
Let's be real.
And if you say she's too fat and she's got no neck, it's probably a fail.
So there was the neck transplant. Spare one over here. What did you do? What was it?
Would anyone have done the joint position sense case?
Oh,
I would.
yeah. So the only thing was did you do any sort of thoracic assessment?
The thoracic was fine. She's stiff. She's like middle-aged stiff, but she was a bit overweight, but to me the thoracic was pretty good.
So I would have thought from that with the flex head posture, there's going to be probably going to have a look, get that upper cervical spine moving better.
We said it was full range.
Or sorry, well, it's just tendon, isn't it? No. Okay.
Upper cervical spine was good.
Yeah.
But she had that forward head flex. Yeah.
Her traps were tight as hell though.
Breathing that.
Breathing, yeah.
Yeah, like just get the breathing out. Yeah.
What'd you say, Jez?
Calm the breathing down.
Yeah, like if try and loosen up in through there, because I mean it sounds like those accessory muscles are working overtime with her breathing.
Yeah.
See if it helps with the anxiety, things like that as well.
Yeah, that's good.
You feel like, well, because we did breath through training, where they like general diaphragm breathing to assist with.
Yeah.
But it's the day stuff that we go.
Oh no, I wouldn't do the gay stuff. Unless that was sort of the training stuff we can do with that. Okay,
Well, there would be,
stability,
but
yeah.
it's been many years since anyone
Yeah.
has done any of that.
That'll be how with our sort of school, but
Oh yeah.
at school, I'm
There's actually a debate. There's actually a scientific debate that a lot of the sensory motor stuff's BS anyway. Like, like it's just the quality of the research is not strong enough.
what about relaxation? We put relaxation stuff with her because once
I think that's a very good idea.
freaking out. And she hasn't had a good experience with like medical practitioners by the sounds of it. It's been a fairly traumatic pathway for her road for her. No, which probably didn't help her coming into physio in the first place. Right. So relaxation, breathing.
Yep, relaxation, breathing. What else? What else might you give it a go?
Okay.
Thanks, Benny.
Was she symptomatic at the time when she came in?
Yeah, she was.
I mean,
Mild.
like, yeah.
Have you got all that?
Is it worthwhile, even just like from symptom relief, does like a snag or something, just that she can sort of, to see if there's something she can do that she can change it, to give her sort of a bit of, to give her more control over the symptoms.
Her upper cervical spine and her cervical rotation was full, but her traps were very tight from what I would expect for her age demographic, and they were tender to touch, and no one had ever worked on them.
So massage and there, sort of soft tissue sort of work through your traps. You can offload it, tape it.
Yep.
Offload
Yep.
positions.
Yep. Yep. Anything else you'd think?
So I kind of wonder if those sort of the bigger sort of movement muscles are working really hard, what's happening to sort of deep neck flexor stuff? Is that worth having an assessment as well?
I think
See
so.
if that sort of like deep control system just needs a bit of work just to get it going again.
Well, there's actually some studies with deep neck flexor that you don't even have to necessarily strengthen them. You can just perform them as therapeutic exercise. So like you can get the patient into supine. They can do some deep neck flexors, like even a set of 10, and then they get up and their range of motion or their traps could be better.
So she's better in supine as well, but she isn't sitting there.
Yeah.
So
that's a good idea.
Yeah.
Yeah, that's a good idea.
But you probably would have assessed anyway, trying to scan, trap strengthening too.
Yeah, probably that. I'd probably look at trap. Yeah, look at trap strength, like a trap strength anyway.
And this patient was doing no exercise.
Well, even just something like that. Just get her doing something.
Oh, she needs something, but it'd have to be.
Need some upper limb stuff, right?
Yeah.
She needs an overhaul. She needs an overhaul.
But she can't be walking. She can't do general conditioning stuff because that makes her dizzy.
Yeah.
So it's almost like you've got to find her starting point is pretty low, like first on the ladder kind of thing.
And also, depending on her, obviously, like fear with exercise and activity as well. Like she's probably would have some fear associated because of all her symptoms.
Absolutely.
So you really need some sort of exercise. Start small that gives her a little win without that little win is not stirring up her symptoms or actually maybe have a slightly positive effect.
Yep. Okay, so let's get real specific. If we're thinking phase 1, like if this patient came in and saw you this afternoon, how many times are you going to see her for how many weeks in phase 1? And you've told me what you're going to do, but
Yeah, like have to wait for 2 weeks and read about it. That's what I think.
we say like what we teach on the master's course here at Curtin in Perth is we say, whatever you think, be specific. So if you think you need to see her twice a week for 3 weeks, tell her that. If you think she needs to be seen once a week for 4 weeks, tell her that. If you think she needs to be seen fortnightly, tell her that and why. So you reckon, did I hear twice a week for 2 weeks?
Yeah, I think I would normally, that's what I normally say to someone, and then just, reevaluate symptoms at that stage, because obviously dizziness isn't something we see that regularly. So I guess symptoms progression over that period, I wouldn't say I have a lot of experience with knowing when they're gonna get changed. So it'd be very
No, I think if quite an unpredictable. If I've got something I can't really predict how it's going to go,
Yeah.
I'd probably say, look, I'm only going to really get an idea of how it behaves after maybe the third or fourth session.
Yep.
With somebody like that, I would have said, similar to Rani, I'd probably go two a week for the first 2 weeks, and then we sit down and have a chat in the fourth. Because then, you know, look, if it's responding really well, great. Then we've got a better.
Love it.
Like it's that kind of thing. That's isn't it a box?
Yeah. Well, my one of the pain professors at Curtin Uni, right? She says she's got this really good phrase that she uses with the complex patients, or the ones where there's like just lots of shades of gray. You're looking at them and you're like, what the hell's going on here? Like, you're like, if I'm honest, I don't know what's going on. Like, you don't want to say that to the patient, obviously. But what you could do is you could go, look, there's a lot more we need to assess. We're going to have a better idea of where you're headed long term if we can do a few weeks of intense treatment. So that's what the pain professor here at Curtin says with these more challenging ones. So you kind of, it doesn't mean that you're copping out to the patient, but you're saying to them, look, we'll have a better idea of like your response if we can do a few weeks of more intense to start with. And I've found that almost always the patients love that they're on board with that. Which basically gives you a couple of weeks up your sleeve to just try different things and assess more and, you know, see how the patient pulls up each session. So it's a bit of a cop-out, but I reckon, honestly, twice a week for 2 weeks for any condition at the start is like a nice little buffer that you can have. And I do that, like if I'm unsure myself, I'll look at them and I'll think, well, let's give it a crack and just try a few weeks and see. And most patients are on board with that, I've found. Yeah. Yep. Anything else? Anything else to mention or question or?
No, I'd be wanting to see how she responded after just starting to eat the simple things.
Yeah.
The other thing with her, I imagine, like a patient like that, they've got to become, if they become comfortable with you, confident with you, then that's going to give you, that's going to help bring things down a little bit too.
It does. Yeah.
Sort of calms it down.
Yeah, absolutely. Like with someone who's had traumas like this, like you got to tread carefully. And she was very anxious. She was very stressed. She was, as you said, she was distrusting of healthcare, full stop. She was kind of like, you know, was worried about whether things would work. And here's what I did. Oh, actually, let me ask you guys. What do you reckon is her biopsychosocial mix? Like if it's like a pie graph, if it's a pie graph, right? What percentage is biological, what percentage is psychological, and what percentage is social for her? Just have a stab in the dark.
I'd probably put bio at about 20, just because I think the psychosocial is contributing a lot of the time. It's just the fact that her range was okay, not too tender to touch and things like that. It doesn't sound like that to me is a neck that would be giving you these symptoms in the absence of that other stuff. So I think it plays a part, but I think it would be less than the other two.
Or at least that's severely symptoms that last, what you say, for 2 weeks. Like that's pretty irritable.
Was the 2 week one? I thought that was momentarily every 2 weeks.
Sometimes
it was flare up that lasts.
Every 2 weeks she'd get a flare up, but then she would also get these flare ups that would sometimes last 2 weeks.
Oh, okay, right.
Yeah. I probably didn't tease that out.
Her biology is kind of like specific in general.
Yeah.
Well, generally she's out of condition, so it's pretty big, but specifically it's probably smaller component.
And I think a big thing I would have checked for her too is what management has she had in the past. You know, has she seen the psychologist? Is there anything she's found there that's helped? You know, knowing anything of that, I think would have been more beneficial to determine how much of this is a psychological, you know, contributor to.
Yeah. So yeah, that's really good. So like one of the things we talk about in specialist training is you go kind of like that neck arm patient that I was talking about. Are we the therapist treating them, or are we managing them? Like, are we the gatekeeper?
Yeah.
Basically. And like you said, Rennie, like essentially, if the GP hasn't sent her to a psychologist, we may be the one that actually has to send her off, because no one else will pick that up. So with that neck arm patient I was telling you, like,
Yeah.
the GP was just, she reckons the patient felt like she was running the consult. And so sometimes, like, I've had cases where if it's particularly complex like this, you actually have to be the one that goes, okay, you need to go to see this person, then this person, then this person, then this person. I might have like 20% to do with your case in terms of treating you and helping to manage you, but a lot of what you're doing is going to be farming out patients to other clinicians. Yeah.
And I would definitely, for this lady, she's already talking about her trauma and how much it still affects her. Like 100%, it's definitely something I would have asked about and queried. You know, obviously you're talking about a typical home life as well. That's going to contribute to general symptoms.
Oh yeah, like it's without doubt. Like, this is one of the cases where biopsychosocial it lands, right? Like, it's not. We can't say it's all biological. It's clearly there's a psychological component. Clearly there's a social component, probably dominant. And yeah, I would say kind of what you're saying, like 10%, 20% biological maybe, and then the others sort of split down the middle, perhaps.
Yeah.
What did I do? Here's what I did. I got her onto her back, and I did abdominal breathing. And I don't often do that with patients. It's not something I normally do, but I just looked at her and I thought, I think I need to get this lady to chill out. She's too stressed. And she came back in the next day, because I have a thing with treatment plans. I only work 1 day a week now, but I teach it to other physios that in an ideal world, I think it's best you see most patients within 24 to 72 hours again for their second consult. And I gave her what we call Mitchell's breathing relaxation technique, 10 minutes 3 times a day. I've heard it explained that it's basically like a volume dial. The volume dial is cranked to full volume all the time, and she's never turned it down. And so what the breathing relaxation can do is start to turn the volume down of her regulation system, so she's not so primed. She came back the next day. She said she was 50% better. And that's the only thing I did. It wasn't exactly like rocket science for me. I thought I didn't think it would do anything, but it seemed to work. So kind of what you guys were saying, which you picked up, you know, if you read between the lines of the case, it makes sense after, right? And she looked totally different. Like, it was quite weird. Like, she looked quite different to when she presented. The next session, I did soft tissue of her traps, and she was like an additional 20% better. And then I gave her some of the more random sensory motor stuff. And I saw her the following week twice. And she described herself as 80% better overall within 3 or 4 sessions. So what's the diagnosis?
It's just like anxiety driven, stress related. Yeah.
Yeah. So it was, that's what I said. I said it was like, I said it was psychological dizziness. And then what, in my head, I just cleared that. So like, this is probably one of the key things out of today, is you just got to clear the stuff it's not. Once you clear the stuff it's not, you're basically left with this diagnosis of exclusion, which is what I felt that she had. And she had little tidbits of impairments, but nothing drastic. And probably, as Dave's suggesting, she's just way out of condition. She's not living, but I still believe that these kind of patients are within our scope of practice. Certainly exercise physiology as well, but I think we are probably the point person to help to get this person to live their best quality of life. Any other take-home messages you reckon from that case?
I think it's the usual thing. It's like, you know, you look at her posture and stuff like that. She's got that flex head posture, and like, all right, there are sort of like mechanical things there, but it's just say, well, that's what that is. That's not what was really driving it first. So it's really trying to pick out what's the major. It's like picking out the major driver and probably going away from that.
Yeah.
Typical sort of muscle physio sort of like thinking.
It is. It is.
Yeah, you're like, I need to poke and prod. Exactly.
And don't get me wrong. I love the manual therapy. Love it.
Yeah.
I do it a lot. But there's some cases where it's just probably not the primary thing. And so I didn't even do it day one. Yeah. And I think in an ideal world with a case like this, it's probably better to not confuse your variables. So like I'm finding more and more, I tend to just try, and this is something they teach you in the master's course, like when we do MSK masters. Basically, the less you can give early, more controlled, probably the more scientific. And you can really tell whether what you're doing is actually helping or not. Yeah.
Well, yeah.
Big factors often when we think about attack treatments. Multiple things, but.
Do you tend to do less now than when you started, or more?
I'll say.
Oh,
Compare what it was like when I did it.
well, when you grad, I think it's a bit of everything.
Yeah. Even just like exercises now, you know, like two things maximum, you know. Just,
Oh, yeah.
Oh yeah.
just do one or two things. It's more just, especially if people haven't got that background, you've got to kind of build their confidence and moving anyway, or whatever one you do.
You do.
I think it's also just it's trying to work out what's good, what's working. Because if you
It
throw
does.
everything, how do you know what's the crucial factor that's made the difference?
Exactly. And what happens if they come back worse? Like, yeah. So like the something I definitely teach now and something I advocate for is trying to get those impairments in rank and order. And then you target the one with a limited strategy and see if you can control your reassessment.
Yeah.
And if you've done that and the patients are better, then it makes everything by deduction makes complete sense.
Somebody said, what was it? Just if you can change one thing and then add one thing.
Yes, that's good.
If you do that, that's probably really good. I struggle with that because I usually go for 2 and 2, but like if you change one and add one.
Yeah, that's good.
But I think the other thing is if you do that in person, it makes the client, I think that builds their confidence with you anyway, because it's like, that's magic.
It is. Yeah. And there's a couple of things on that. Like there's some recent research that shows that patients get overwhelmed if you give them more than a couple of things anyway.
Yeah.
They actually get what's called the backfire effect, which means they actually get angry. Like they feel like they shut down because they just internally admit that it's something they're not going to do.
Even the ones that are super keen to want to do everything, I think it's just like, no, just bring it right down.
Yeah. There's some cases, like I do a lot of knee, right? And like if it's a non-surgical knee or a post-op knee, like I'll give them a lot more exercises than this lady.
Yeah.
But I think it's a good principle to defer to giving less and there's some cases where you'll treat multiple areas on the same first session. But when I was a new grad, I used to throw the kitchen sink at them, just everything. And I'm probably more judicious now. And I think the patients, and you can even say it out loud to the patients, say, look, I'm intentionally not doing a lot because I do not want this to flare up. And I really want to make sure that this is as controlled as possible to get you the fastest outcome, the safest. You know? Yeah. All right. So with the differential diagnosis of dizziness, okay, it's like I said, you sort of have to rule in and rule out. There's different tests that you can do to further prove one's predominant over the other, or it's been cleared. So like I said, like you've got dizziness is different to vertigo. So I always ask the patients that specifically. Does it feel like it's a carousel where it goes up and down, or like waves where it's going up and down? Or is it more spinning? Because it's different, and it might give you more of an indication as to what's going on. It's a lot of, do you guys do a lot of GP education?
Yeah.
This would be a topic, I mean, I can send you these slides and you can just use these slides, but a lot of GPs don't know that physios can treat dizziness. So it is actually something that is probably worth speaking to doctors about, because it's a large part of, it's 1 in 20 patients will present with dizziness. You've got more peripheral versus central. They're your two, like if you're sort of striating them, you have like more BPPV type, where it's rapid onset, severe, nausea, vomiting, auditory, and nystagmus. And then you have more central, where you're thinking it's something more sinister. Most vertigo spinning is peripheral. Okay. And these are the sorts of things you'd get. Meniere's. Have you ever seen anyone with Meniere's disease?
I've seen people have had it.
Yeah. BPP. How many BPPVs do you see a year?
Yeah, minimal.
We'll get a few inquiries for that. We'll get a lot of inquiries for it.
Okay. Post-traumatic vertigo or post-concussion syndrome?
Yes.
Get a few.
Yeah, that's almost a whole nother topic. Well, it is a whole nother topic. There's a guy on my team that does that one. Labyrinthitis. I've had that. It was horrific. I woke up, it was about 15 years ago. I woke up this one morning and I'd been to the footy the night before. And I had some dodgy pizza, right? But the pizza actually, my wife woke up and she was vomiting. She had food poisoning. And I woke up and I felt sick, but the room was spinning. And I hadn't been drinking, I promise you. And I felt like I just couldn't, I looked in the mirror and I could see my eyes beating. And I had a severe headache. And my wife took me to emergency and they did a CT of my head, which was clear because they thought I'd had a stroke. And then they did all the BPPV tests. It was fine. Did the head impulse test, fine. And then I just couldn't stop having vertigo episodes for probably about 2 weeks. And then they gave me Stemetil. Do you guys know Stemetil?
Yeah.
They overprescribed it. So I had a tonic-clonic reaction. So I was, the next day I was lying on the ground and I started getting these seizures. I was fully alert, but like I was like this, like, and my arms were coming up and my jaw was locked and I couldn't move. And my wife was freaking out. So she called the ambulance and was swearing at the emergency, and they picked me up and then they then they took me to hospital and gave me Valium and knocked me out. She reckons I was just lying there with my eyes rolled back. So anyway, the moral of the story is you can have other causes than BPPV or VBI. And I haven't had any since, thank goodness, but it was horrible. And then you can have cervicogenic dizziness, which is kind of like the exclusionary diagnosis. It's like, some people call it a diagnosis of convenience. Have you heard that phrase? Which is basically, we don't know what's going on, so we're just going to call it this. like fibromyalgia kind of.
What's that called? Yeah.
But obviously physios have picked up strokes before. So I've had patients, like I had a patient, sorry, a physio that I mentor, she picked up a stroke in Queensland a few months ago. So you've got VBI, MS, tumor, stroke, TIA, that could all be features. There's lots of them. So you've always, that's one thing. Did you guys work straight into private practice, or did you, yeah. So if you've worked, like I worked in a hospital first for a couple of years. And so these are the kind of presentations you see in hospital. How about you, Dave? Did you go into private or did you do some hospital work?
I did the hospital first, though.
Yeah. So like I just spent 2 years in a hospital. So I saw all this kind of shit. Like you see, this is the sort of stuff in the very back of your mind, you've always got to be thinking, is this patient got a red flag? I don't see too much of it in private now, but in hospital, it's the majority of what you see. But they could present to primary care with this stuff. So there's hundreds of potential causes. So always think non-musk first as a screening. It's very good advice that I've been told. Obviously, if they have VBI, it's occluding their posterior circulation. So if that's being occluded, the parts of the brain that control signs and symptoms will be affected in the posterior circulation, okay? So the medulla, the cerebellum, the pons, the midbrain, the thalamus, occipital cortex. So this is why patients get those 5 Ds, 3 Ns, and an A, because that's being affected. Does that make sense? There are risk factors. In fact, actually, I'll get you guys to write them down. Can you write down eight risk factors for cardiovascular?
Cardiovascular disease.
Yeah, give me 8. There's heaps, but
Genetics, age, obesity, smoking, diabetes.
Probably not, no.
Cholesterol. Lifestyle. Got genetics, that's the kind of trait.
When, you know.
All stored environment.
No worries. Thank you so much for
Well,
letting me know. Thanks, Hayes. Bye.
Iatrogenic, so like drug.
Thank you for calling.
Yep.
We've given you 8.
I'm happy with it. I'll take it. So, cardiovascular. So, like the reason I ask you this, I don't know if you guys routinely screen for this. I'm sure you do, but it's probably the cardiovascular risk factors that are more predictive than the physical tests. So, like your VBI, sustained rotations and stuff, they're not as predictive as the person's screening. So you have to screen. Obviously, smoking, diabetes, obesity, hypertension. You said those questions. Always screen those questions, right? I have sent 3 people in my career for carotid ultrasounds because I believe they had a positive VBI, but it's actually better to send them for an MRA. This would be the reference standard. Do you guys you guys are where are you? You're in, yeah, and are you close to a major city?
We're in Brisbane, yeah.
You're in Brisbane, yeah. For some reason I thought you were rural. I don't know why.
Just sounds rural.
Sounds rural, yeah. But this is better. And interestingly, so like it's the whole thing, right? Like ultrasound will undersell, MRI will oversell. But if you're at all suspicious, I would send them off. But this is what I was saying before, like this double-blind randomized controlled trial showed that you're more likely with the physical tests, they don't pick up abnormalities on MRA as good as the risk factors. Does that make sense?
Yeah.
So this study showed that if you have 3 of those risk factors, you're more likely to have positive findings on MRA than doing the physical tests. So I basically don't hold the physical tests with much credence. Does that make sense? There's quite a few. So obviously male, age over 55, if they've had a TIA, emotional stress, less than 4 hours physical activity a week. So this would be a lot of the patients that you're going to see in clinic, right? So you've always got to keep a short leash on whether you're going to on-refer them. All right, let's practice. So show me how you guys do the VBI test. This is like a pop quiz from school. This is like a pop quiz.
I just.
Did you demonstrate?
Yeah.
I'll see it.
Show me.
Okay.
Do it on Dave.
Turn the face in. Yeah, so actually do face that way. So from the chair point of view, so basically, so turning head to side if they've got good neck flexion, cervical range, because they don't have a rotation range, and then looking at their eyes, any sign of nystagmus, keeping in that position for 20 plus seconds, and asking them how they're feeling. Just if they're getting any sort of dizziness or feeling faint or anything like that. And then slowly go to the other side. That's what it is.
Okay.
I remember there's another one. I can't remember the difference.
There's like you can rotate them and extend them.
Yeah, you want to be more like.
Yeah. So you rotate them and extend them, and you hold it for 10 seconds.
Okay.
And you just hold it there, and you look at them and you just hold. It's a bit awkward, really. You're staring into their soul, but you just you hold them there, and you keep it there. That's the most provocative. And I would just hold it, and then once they come, but then I bring them back to the middle and keep them there for 10 seconds, because there could be a latency. And then I go to the other side. You could get some weird. It wouldn't. The most important thing is that you check it and put it in your notes.
Yeah.
Because there's lots of debate. There's lots of debate at a national level, like medico-legally as well. My mentor, who was a specialist physio professor and a private practice owner, he was also a medico-legal expert. And he was mainly brought to court as an expert witness against chiropractic, because that a patient would have a VBI episode post high velocity thrust of the cervical spine, and they hadn't done any of this testing. None of it was documented. But technically, even for MOBs, you've got to do it. Even just cervical MOBs or snags, because you're taking the person to end range rotation. And what's even more confusing is a lot of the VBI tests we just did, even on ultrasound, it doesn't even include the carotid or vertebral. But you still have, but from an APA point of view, we still have to do it and document it. It just covers your ass. Physios are fine. It's normally like the random Turkish barber that just does a manip at the end of someone's, or like a hairdresser that does it, or the chiros. They're the ones that would be mainly prosecuted. The other ones you can do are blood pressure, we said, the craniovertebral ligament testing. Let's do that actually. So can you guys show me what you do? So have you got a bed?
Got a bed? Oh,
Can you-
we're not in a room, we're at reception at the moment, I'm afraid.
Ooh, could you show me on the ground?
Not really. Not really.
No lie,
You lying there?
that way.
Oh, really?
I'll have to make it work. Fly an angle, you can lie an
Where do you
angle.
want me?
How's the structural integrity of it?
Oh, that's fine.
And that is not the issue.
Yeah.
That's doing it.
What do you want me?
I'm not gonna be able to. Do that.
You can't get, put your head off the hang of the edge.
Can't hang off that edge.
Like,
Go on, right, I'll put it that way.
Where do you want me?
Yeah, this is gonna work too well. Yeah, I don't think this is gonna work too well here.
That's cool. Well, what do you guys normally do? Which tests?
Sharp parser?
Yep.
It's just like, I can't remember the actual names of them now, but it's that sort of just getting that feel like AP lateral glide, that rotation.
Yep.
And there's even sitting, there's like, I just remember it like the neck, where you start to feel like the translation of the skull on top of the neck as well.
it's
Yep.
got your ligaments, sectorial membrane, I did. And one more that I can't remember what it's called. I'll stop my head.
Look, personally, I do so much knee, it's not funny, right? And I get the Lockmans wrong all the time, and that's pretty easy. So I would, if I had any suspicion that the patient had upper cervical instability, I'd probably send them off. Like, and if you're gonna do it, like, you've really got to, you know, you don't want the patient coning out on the bed, like. So it's the sharp purser. You can do it in sitting, and you relocate C on 2. It would, the sort of features the patient would have would be what? Pins and needles in their face, pins and needles in their head, bilateral pins and needles, cord signs. It's hard because, like, a lot of the time, like, it would be more like after whiplash or something. But cervicogenics dizziness is highly related to whiplash.
Yeah.
That's probably the main cohort you're going to see. But you could basically, you're moving C on 2 for the sharp purser. The alar ligaments is your fixing 2 and then side flexing the upper cervical. So you're kind of pinching here and moving their head from side to side. You could do it in sitting. So if one of you just wants to grab the other person's neck. You pinch.
There's some things that
Yeah, you do that and you just side flex, but you shouldn't feel, you should feel like it blocks.
Yeah.
Yeah, and it just doesn't, it won't move. The like 2 won't move when you, but it's not far, it's like 10 degrees max. It's a tiny amount of movement. And if it feels like it keeps going, then they may have some alar ligament instability. Yeah. The other one you can do, which I was going to try and do up on the bench there, but it's obviously probably a health and safety issue. You can lift their head and occiput up. So you lift C1 up in supine and you hold it there for 20 to 30 seconds. But same thing, and that's for transverse ligament. Yeah. But personally, if I was thinking any disruption of these, I would be probably I would be probably referring on myself.
They're really easy. Yeah,
How accurate are these tests?
Not so accurate.
and if they're a trauma patient, then most likely have scans and stuff.
Yeah, they're gonna most likely had scans. But like my special interest is non-surgical anything musk, right? Non-surgical whatever. But if you like non-surgical shoulder, non-surgical back, like if you look at upper cervical, like it's a case-by-case presentation. Like there isn't any metadata to show that someone with cervical instability is going to be better off with a non-surgical program versus an ORIF of their upper cervical spine. Because it's obviously very risky.
Yeah.
And so it's like they're basically, most of them are going to be conservative anyway. But it's just how you manage them early. And as you said, they're probably going to end up in hospital first.
Most likely be a trauma.
Yeah. What else we got? Carotid artery palpation would be the other one you could do. Now, what about BPPV?
I know.
So, pretty common. Pretty common. What was that?
Rachel's also saying it's been a while.
Oh, look.
Post-traumatic placement disorder.
You guys asked for this topic.
Exactly.
This is why.
I don't know much on it.
Yeah. Oh, look. As I said, like I only probably do 1 or 2 a year, but I'm confident enough that if I know this stuff, I can triage most people. Most of it resolves on, well, 20% of it resolves on its own. But like you still treatment plan them. You still give them a treatment plan because it might not, and it can recur, which is the whole thing, that you don't want to just send them away if they're not. Another thing with treatment planning with me is I don't discharge these people if they're not 100%. It's the posterior canal, which tends to be the more dominant one. But the whole thing is you just don't, you'd probably see them minimum 3 or 4 times on average, I would say. So if someone asked you, you'd see them at least 3 or 4 times, probably in that first 2 weeks. I describe it as ear rocks. I say to the patient, you've got ear rocks that have displaced. And most of the patients understand that. But it's different. So if you compare this to what that lady was describing, it's very different. Or even to VBI, it's quite rapid. It comes out of nowhere. They get it rolling over or sitting up fast. And it's short acting, but severe, related to movement. So quite different. The reference standards or the gold standards would be MRI of their brain to clear anything sinister. The Dix Hallpike. Do you guys know how to do the Dix Hallpike? So if that's so you turn their head a little bit, a bit of extension, and you just the key thing is it's got to be rapid. So you like, that's the one thing as I said, I don't consider myself a guru, but the one thing that a lot of vestibular physios will pick up is the physios and the clinicians who are attempting this treatment don't move the patient fast enough into rapid extension. So you have to basically you have to throw them back fast while supporting their head. You can also do the head impulse. Do you guys do that as well? I'll show you that. And then there's the supine roll. So you can see this one. So that's that you turn them probably about 20 degrees towards their affected side, and you go with their affected side first. This would be one of the instances you do go for their affected side first.
Sorry, Kieran, just a quick question on that, mate. So when I got taught, I was confused with this one because they said that you do this to test which side is affected. Something to do with the direction of the nystagmus, if it was upbeating or downbeating and any torsion in there. And I was like, oh, I can't see any of this stuff. Yeah, I think beats towards the affected ear, is that correct?
Generally.
Yeah.
Generally. But like me, man, I get it. You actually probably need the goggles to see it properly. So I get it wrong all the time. And we've got do you guys have a vestibular person that you send to?
Oh, yeah.
Yeah.
Yeah. I'd probably give it I would give the patients 3 or 4 sessions if you think it's posterior canal, which is most of them. And then I would just refer on. But how I was trained and what I've read is that you would go where you believe the nystagmus beats towards that affected side. And I would do that side first. If that makes sense.
And would you go straight from that into is it Epley's?
I do. Yeah. So yeah, I go straight from that into because that's why, most of the time we check the unaffected first, right? But because they're already pretty symptomatic, it's likely to be symptomatic. You take them straight into the Epley's from there.
Are you often guessing what side is affected basis on, if they've got particular sides of getting out of the bed or things like that bring on symptoms? Are you already having an idea anyway, even if we can't visualize the nystagmus prior?
I am. Yeah, I would. What was that? I missed that.
The direction of the vertigo also is like right to left.
Yeah. Yeah. And you're trying to go on like a balance of probabilities. Like you might get it wrong, but yeah. If you get obvious nystagmus on the side that you chose first, then you would go straight into an Epley's normally. And most of the time in primary care, you'll get it right. You can also do a head impulse. So you get the patients to keep looking forward. Have you seen this one?
Yeah, it's been a while.
Yeah. And then what you find, you take them to 20 degrees. And then because you're telling the patient to look forward at you, right? So you're in front of them with your hands on their head, and then you move their head rapidly 20 degrees, and they should be able, normally, someone's eyes will keep looking at you. But if they've got BPPV, or vertigo, their eyes will go to 20 degrees and then quickly bounce back, which is abnormal, which would be a positive test. Do you want to show us that? Do it.
I don't think I could do with that.
Has Dave got a bit of a weak stomach?
Dodgy.
How quick is it?
Are we going quick?
Fast, yeah.
Or quick back? No, quick two.
Quick 2. Yeah, so if you
As in
look at
like
my, if you look at my nose,
as in quick turn and slow back.
It's quick and quick.
I've looked at the same time.
Just quick back at one movement.
I say click
You go quick and then quick back.
All right.
Cause I feel like.
There's a bit of a pause when you get to that 20.
Yeah.
Yeah, then you pause it when you get there.
All right, okay.
Show us.
Okay. Yeah, so yeah, look at my nose. Good. Yeah,
Fine, I can see. You're past that.
It's
Awesome.
That's not a exact diagnosis of like BPPV there as well. You're just saying it's generalized vertigo.
Yep. You got to take all of this stuff in balance. Yeah. Yeah.
just building up evidence, isn't it?
It's just building up evidence.
Well,
And
it's-
got the supine head roll as well. So we were taught that basically if their Dix Hallpike is negative, then it's not BPPV, but that may not be true. So they could have it more lateral canal, which is less common. So you can do this this head roll test. So you have the patient supine and you bring their head to 30 degrees flexion, right? And then you quickly rotate them 90 degrees to one side. And you leave it for like minimum 5 to 20 seconds up to a minute and just see if they get any nystagmus at all and sensations of dizziness, illness, that kind of thing. Then you bring them back to neutral, supine facing forward, and then you do the opposite direction. Supine head roll for lateral canal. Yeah.
This return to upright, does that have to be with any speed? Or is that just slow?
Nah, you do it pretty slow. Yeah. Yeah, I wouldn't do it quick. Like with these patients, other than the actual movements that you're performing, the tests, everything's pretty slow.
Yeah.
So what treatments? This is your Epley's.
It's been a while.
So you bring them at the start of it is like the Dix Hallpike, right? So you take him to that position and then you turn their head 90 degrees away. And then you turn it a further 90 degrees the other way and you're rolling them onto their opposite side. So if you look at it like that's for the positional movements, but this is the idea of what you're trying to do. So I'll often pull up this picture on Google, and not just because I can't remember it, although sometimes I can't. I'll show the patient what we're aiming to do with the ear rocks is like move them around, so to try to move them back to where they would be. But everything is about that kind of 5 to 20 up to 60 seconds in between movements, so you don't piss them off too much. And you do actually have to have the bucket ready. Works most of the time. This is what I'm telling you. If you've cleared VBI and you feel like they've got BPPV, you pretty much can, like everything in life, right? Like it's always like a risk reward ratio. You would be thinking, okay, I reckon this is there's potential here. Highly likely, really. There's like.
You just do it once. No, I was just thinking that. Is it once in one session?
It's once in the first session.
Yeah. Mm.
But then I would back it up in a couple of days.
Yeah.
And you can teach them to do it at home maybe once a day, unless you think they're really low irritability and you could do it like, say, 3 times a day. But as the clinician, you would do it once. If that doesn't work, you've got these other ones up your sleeve. There's the Samont liberatory maneuver, where you're kind of going from side to side. Have you seen that one?
No.
Looks like this.
Is this for like
Yeah.
is that for like the cupulolysiasis?
Matt, I don't even know.
Old dizzy patients to Jeremy.
I don't even understand the question, let alone the answer.
I'm saying it was.
So we're going to talk. So the difference between a canalolysiasis and a cupulolysiasis is where the otoconia gets stuck, it's in the canal or on the cupula.
Yeah.
Therefore, when you're looking for the nystagmus, if it doesn't fatigue within 60 seconds, then you're thinking that it's in your cupula. And so that's when you do. Which one? Yeah, the bump and dump.
The short answer, like the kind of clinical answer, is you would do the Epley's, and if it doesn't work, and they're not too provoked, you could try this.
Okay.
And so the diagnosis is almost irrelevant. It's just like, just that's my cop-out answer to I don't know.
Yeah, I told you so.
Oh, I definitely was. I look at it and I go, oh yeah, that's right.
Yeah. But we used to just give this to people. We used to give this to people in the hospital if Epleys didn't work. That was like, that's what we would do.
Clinical reasons didn't work, do that.
Yeah. What else could I try?
Yeah.
How else can I throw them around the room? It's pretty easy. It's the same. It's those same principles like you said about fatigability. Like if it fatigues, then it could be, but you just got to give them that 5 to 20 to up to 60 seconds. And then you try the other side. If you think it's lateral canal, then you can do the barbecue roll.
I remember this.
Hey?
I vaguely remember that.
What you do is you have them in supine. You turn their head to what you believe is the affected side, and then you roll their head 180 degrees the other way.
A lot of rolling on a small plate.
Yeah.
And fast as well, yeah, rapid.
Pretty rapid.
Yeah.
Now, one thing that I've learned is because you always, like you said, what did you say, Dave? You said you do one thing and add one thing. So you do one thing, so you've done a treatment, and then you add stuff for home. I typically get these patients lying in a comfortable position. Just try and base it on how they've presented, but in as most comfortable position as possible. Ideally, not going into their provocative position, because some of them don't know that that's something they should avoid.
Do you prescribe those, like, is it Brant Daroff exercises?
Yeah, Brant Daroff or Cawthorne Cooksey exercises. Like, look, good question.
Oh, okay.
Most of the time, with someone who's highly irritable like this, I don't give them anything I haven't tested in the room. So I'll normally follow them up. I practice what I preach. Like I only work 1 day a week now, but with patients, so I'll get them to see another physio, normally the senior physio in the clinic I consult to. And so I'll get him to see them, but I won't give them any funky new stuff that I haven't tested in the clinic. If that's fair.
Yeah.
But the metadata would say it is better that they are cautious at home early after the treatment than just leaving them with general advice. It's not often I do this, but you could do cranial nerve tests as well. Basically, if those two are clear and you've cleared those other sinister things like we said at the start, you're kind of left with cervicogenic dizziness. That's how I think about it. I've cleared the red flags. I've cleared something I could treat, which is BPPV. Doesn't seem to be that, but they still have this wooziness. It doesn't seem psychological. They've probably got cervicogenic dizziness. There would be some neurologists who don't even believe in cervicogenic dizziness. They just don't believe it's a thing. But it's kind of similar to cervicogenic headache, which also some neurologists don't even believe in. But basically, you've got this dysfunction of their neck, and even though there's no direct nerve to their inner ear and eye, there's this secondary convergence in the brainstem. So because you've got this dysregulation of your neck, the patients have sensory effect in the inner ear and sensory effect to their eyes. Does that make sense? It's basically only by exclusion. Pretty common with cervicogenic headache, very common with chronic whiplash. That's your big one. And that's where I've seen it most. And granted, I don't do a lot of whiplash either. But if it's a screening question if someone comes in long-term post, because it may change your treatment strategy and management strategy. There's some pretty good papers on it. These papers that I've included in this talk, just remind me, I can send them to you if you want. Basically, like I said, you clear cervical spine frank fracture. You do your ligament tests, you do your neurological screen, you do your vestibular test, then you do your joint mobs, traction, AROM, and then you can do more your neck torsion tests, your relocation tests, your kinesthetic tests, which have got limited validity, as I said earlier. And then you treat the impairments. Do you know what the best research is for in cervicogenic dizziness? The level 1 evidence. Snags. Cervical snags. So what do? I would so we can practice it if you want. So if Jez, you want to sit forward a bit and someone just sit behind or stand behind him. Okay, so if they've told you that it's a certain direction, rotation, flexion, extension, I will get them to slowly move into that. The other thing you have to be mindful of is some patients, there's a dysregulation, but like that girl, she was talking about reading the book, the one at the start.
Yeah.
So the good physios will actually delineate the eye movement first. So you get the patient. So if you could actually stand in front of him if you wanted to first, actually. And you get him to look. You get him to look to the left first. So say, look to the left. And then turn your head to the left. Now come back to the middle. Now just turn to the left. So there might actually be a difference in dizziness when you delineate those two. Does that make sense?
Yeah.
Yeah. And it's the same with looking up. So you just say, tilt your head up. Okay, come back down. Now look up. And then lift your head.
Yeah.
The thing that's quite interesting, right, with a lot of these chronic whiplash, everyone put your fingers on the back of your upper cervical spine. This is a bit spooky, this. What I want you to do is just look up with your eyes. And look back down. Look up again. And back down. Now look to the left. Now look to the right. What did you feel in your neck?
Nothing.
Watch your fingers.
Oh, yeah.
There's a little.
Watch your fingers.
Yeah.
Well, Jez, you probably need to spend more time in the gym doing neck day. Because you actually can feel a little bit. There's a little bit of muscle activation when.
Oh, there it is. Yeah.
Yeah.
I was really pressing it that day.
Gonna move it.
Yeah.
You got a too fat and weak neck. So yeah, so that there can be like dysregulation there with chronic whiplash. So I would be, it's not like, it might not be the game changer, but it could be something the patient needs to work on, right? But then if you stand up behind him, if there's dizziness, the classic rules with Mulligan, right, were that you apply a direction in the treatment plane, was what he would say. You then turn their head to their affected direction. You then have resolution of their range of motion and their symptoms are abolished. That would be an effective treatment. So specifically for cervicogenic dizziness, this test has been validated in Australia, actually. Large study, good studies. So you put your thumbs onto his C1 or C2. I would direct it probably up towards his eyes. But before you do that, you just hold it lightly and get him to turn his head to the left. Okay, come back. Now, when you push in and get him, and you hold it as he's turning. Show us. And then as he comes back, you keep holding it. And then you let it go. That's how you are best to perform that snag. It's either going to be with flexion, extension, or rotation. It may be with side flexion, but it's normally that. Okay. It could also just be that their articular process or facets are just stiff and sensitive. So if you, on Jeremy, can you palpate the right side of his C1 articular process? And do like a PA. So you've got a PA you can do. You can do a PA on the facet joint of C1-2, or you could do a PA on the articular pillar of 2. And then you would compare and contrast that to his other side. You would expect it normally more with active range of motion, but it could actually bring on dizziness just by palpating it. You would then go through and do these tests. Eye follow, which kind of, if you're doing eye follow, you're starting to think it's more central anyway. So you can go in front of him and just get him to follow a pen across his eyes and see if he gets any, or use your finger. Gaze stability. Gaze stability. So you hold the pen and they turn their head while they're looking at the pen. And the smooth pursuit neck torsion test I'll show in a sec. This neck torsion test, have you guys got a swivel chair?
Yep.
Go stand in front of Jez there. Or sit in front of him. You keep his head in neutral. So put your hands on his head.
Outside of the face in neutral.
Yep. Then you rotate. He rotates his trunk 45 to 90 degrees.
These are
These are like, yeah.
When it's either during or after, like this. So you can do it from the front or the back like that. This is it's those two tests. It's the snag and this that are the most valid and reliable. For cervicogenic.
And you're holding that rotated position for 30 seconds.
Yeah. Well, that you hold their head and it's just the patient that swivels.
Oh, I think are they turning back and forth?
No, they swivel and hold it. So if you put your hands on his head, put your hands on his head. Yep. And then he turns, holds it there. He holds it for 30 seconds. Yeah. Yeah.
Is that,
Go from the back, because it's less.
that was the one with like the DPI where it's like you turn yourself.
Yes.
Yeah.
See the difference? This is the smooth pursuit neck torsion. So they turn their torso 45 degrees. So you put your finger in front of their face. And then he turns his torso. But his head stays the same. This could give them dizziness.
Wait, so turn to like that.
Okay.
Is that better?
Yeah.
Yes.
Yeah.
Yeah.
Like your rate. How good.
I think I could, but I'm only on 45. I feel pretty good. I'm only on 45.
Yeah, but it looks.
I might not be 45.
This joint position error,
Yeah.
I don't have a, even in the specialist exam, when I sat the specialist exams like 7 years ago, I didn't even have a laser. I probably should have had one, but I didn't. So what I did was I got the person to stand, the way I do it is you get the person to stand like 90 centimeters away. So it's like roughly arm's length. And they face the wall. So it's probably better if one of the girls faces the wall now, right? And I would use you, Dave, but just for lack of hairline there, if you're sitting down,
Lateral damage.
if you sit down and face the wall, right? And then someone stand behind her, put your arms straight out. What I do is use you can either, like if it was Dave, you could use the bridge of his nose, or if it's a patient that's got a part down the middle, you use the.
Oh, yeah.
Do you see what I mean?
Yeah.
See what I
and
hear
you
you doing now.
And then I'll draw a line or a mark on the wall, and I'll say, look, I want you to keep focused on that, and then I'm going to get you to close your eyes, and I'm going to turn your head,
Oh, yeah.
and then when you come back, I want you to tell me where you see the dot is, and then you just remark it as opposed to with a laser. Do you know what I'm trying to say?
Yeah.
Yeah. So that's like the poor man's version of doing it without the laser, which is what I did. And that often people will have a difference, right? But if they're getting dizziness associated with it, then it could be an impairment you need to target. Okay.
And again, is that done at speed?
No, this one's not really done at speed. No, this one's just more
It's a smooth movement.
smooth movement, and that they're often going to have a difference. But the argument from a lot of the researchers, actually from Queensland, is that it's going to be more dysregulated with someone who's got cervicogenic dizziness than a unaffected control.
Right.
But that's up for debate. You can also just check
the normative values for.
Yeah, I knew you'd ask that. I knew someone would ask that. I can't remember. I can send you the papers, but I think it's like 10. I think it's like 10 centimeters or something. I think it's 10 centimeters, maybe. Yeah. So if it's like more than 10 centimeters off consistently, then you'd be thinking, and they're getting dizziness with it, then you'd be thinking, shit, okay, this is probably something I need to include. But the most reliable are the neck torsion and snags anyway. So this is kind of a Hail Mary test, I think. I try to go with the tests that are the most rigorous, right? But you could have a patient that this changes the game for. Like it could be that their symptoms might be, say, if they're like reading a book, or like if they go for a walk and they're looking around, they start getting more dizzy, that kind of thing. There's a few different types of there's like, as I said, there's a couple of randomized controlled trials that do show that. Do you guys know how to do this snag with the towel or snag with the belt?
Yeah.
So how I teach it is I get them to, has someone got a towel there?
I'm going to tell you.
That's strap.
Use the strap. No, you usually get straps or webbing for it.
Have you got the strap?
No, we just buy webbing from Bunnings.
Oh yeah, that's good. Yeah, nice. The way I teach it, right, is I get them to, where is he?
Let's go and get it.
Okay. You get them to hold their hands out in front, and then they switch hands. So you hold hands out in front, and then change hands. Yep, and then you pull one hand down What do we got there? Yeah, that's it. And then turn to your right, your head to the right, and you pull it along your cheek. You've got it. That's perfect. But Dave, your hand that went down, it's got to pull more downward. And then and then as you come back, keep pulling. He's got it. Textbook. Could be one of those anatomy models.
Thanks.
We'll have to get you nude to do that and put a black strip across your eyes.
I'd rather know. Broken internet.
Yeah, so that's one you give them for home. So like always, obviously, I like that thing you said, give something, add something. So like that, this is a very easy evidence-based treatment for, yes, neck pain, but also dizziness. There's actually other treatments you can do. So you can do traction. So you can do like sustained, if the patient comes in with dizziness, there is actually systematic reviews that show that tractions can be effective as well. So not just snags. So putting that preponderance together, you're always thinking it's unlikely the patient is going to come in with like just one. Even cervicogenic dizziness is going to have features of psychological, biological features, possible social features, and then you've got pretty hard evidence that, like, if it's BPPV, you can treat that way. If it's not, but if we're talking cervicogenic dizziness, the whole thing is proving what it's not first, and then what you're left with is actually pretty easy to treat. A lot of these patients, as I said, though, are probably going to have more articular problems, like what we said earlier. They'll probably have the weak deep neck flexors. They'll have the lack of range of motion in their neck. You can honestly, in my head, I'm thinking more classic Musk neck, and then I'm thinking this sensory motor stuff as like a add-on.
Yeah.
It's not really, like, the research wouldn't say it's typically the dominant feature, but it could be, but it's probably not going to be.
It's kind of thing, if you've cleaned up the articular stuff, you're still left with residual symptoms, then dig a little deeper at that point.
Yeah, but if, like, so that's why I didn't buy the laser, because I could pretty much justify that if I'd screened it and it doesn't show anything, then it's probably not a dominant impairment. Do you know what I mean?
Yeah.
So, and this, if I manage the patients that I've had that have true cervicogenic dizziness, this is the thought process that I use, and it's pretty defendable, pretty straightforward. But in terms of the impairments, that's a whole nother topic. Like the types of impairments that you treat, like, and the strategy, the exercise strategies you use for upper cervical motor control or generalized neck weakness. If there's a scapular related component, this is a whole nother. Yeah.
Another topic.
A whole nother topic. Yeah. Series of topics, really. Yeah. Has this been helpful?
Yes, I think I would enjoy that.
Yeah. And that's like, it's probably not, a lot of clinics ask us to do this because it's the kind of, I don't know, it's those one or two that you might see a year that it can be a bit, you can get a bit overawed because it's just not our standard thing that we see.
Yeah.
But there is research evidence that physio can treat it. It's not like this token thing. You can actually, both for BPPV, well, certainly in primary care, I've had heaps of physios that have picked up red flags that GPs have missed. Yeah. So you gotta know that we have a vital role in healthcare. Yeah.
Yeah, I think it's really useful. Really good.
And yeah, so like in terms of what we do, I think I've sent you the list of our topics. We do.
Sent that, and I sent you back. I think I sent to Tammy just what I was hoping to do next year. Because I'd be pretty keen to pursue that actually.
So what do you guys feel like you need? What's your major?
What do you want?
What's your cohort? What sort of cohorts do you
Well,
see?
it's a bit different in the development where they are and where their interests lie. But that's why when I sort of emailed back, my sort of thinking was, is it, you know, if it's possible, say like we had like a group session, say if we do it over 6 months, like 2 sessions where it's a group sort of tutorial like this on a clinical topic.
Yeah.
Probably relevant to what we're doing here. And then the clinical reasoning for individual clinicians, like just stuff like that, 2 months, like I thought, like say, for 1 month, you bring in your 2 or 3 patients, then we can follow up with that and then add other things and kind of do that individual treatment mapping because I just think I think we need a different voice here or different voices.
Yeah.
Just to learn more, to be exposed to different ideas and it's just to keep the momentum going and
yeah, I mean, like the consultants and myself, like we're reading like 2 to 3 papers a day. Like we love this stuff. So like and the research does evolve. Like it's much the role for physiotherapy, in my opinion, has become even more necessary since I've graduated. Like we've got so much we can do to help patients and we can prove it. It's not like pseudoscience. It's actually, you can really help patients get better. And if you know there's new information that can actually help you get patients better quicker and more robustly. And I think I was saying to you, Dave, like the physio, like there's some, I mean, I'm biased because I run an education company, but the physios who avail themselves to second opinion are normally the most competent because they're always considering a counter perspective. It's the physios who kind of like cloister themselves against someone saying something maybe that they haven't heard, that they're probably not the most competent.
What I'd like to do is we'll probably all have a chat together and then what we'd like to do, what we'd like to gain from it. And if I get back in touch with you and Tammy, and let's see if we can arrange something for next year.
Yeah.
I'd like to get something regular going for the clinic, to be quite honest.
If you are going to bring cases, the other thing, like I said to you, Dave, is you can each physio, so all you guys there, you write down your key strengths, growth areas that maybe you haven't invested into, and that's the stuff that we can target. And that way we're not savage. We won't dress you down. But it's good to hear. That's what I did. I when I was getting formally mentored was when I learned the most. Yeah.
No, I'd like to do that. So yeah, if we have a chat, if I get back in touch with yourself before the end of the week, and we'll see if we can arrange something for next year. It'd be brilliant.
Sounds good, guys.
Yeah, I enjoyed that. Thanks very much.
Good to see you.
Yeah, we'll see you again.
You got patients this afternoon?
A few patients this afternoon, yeah.
Hopefully some busy ones.
And if they're not dizzy, you can make
Are you
them
sure you're not busy?
Look, I'm just going to quickly check your Dick's hall pipe, but it's my ankle. We need to do it.
Don't worry.
Could be coming off your inner ear. Don't worry. All right. All right. Okay. Well, I'll be in touch before the end of the week. Oh, in the next week.
It's like, I was gonna say that's tomorrow day.
I was going to say. I just realised that just now.
It's like,
I know what that feels like. Yeah.
just take your shirt off and choose that.
Can we get a copy of those slides and maybe the reference list for that topic today, so we've got that on hand?
Yeah, of course.
Yeah, and that's it. Anyone asking?